Well, baby, you've been on my mind. I think about you all the time. Oh, I want to see your face. That don't make me wait.
Welcome back to Sleeping Around the podcast. This is a very
Sleep divorce.
This is a very, very special episode. Again, we have Dr. Ann, Dr. Brandon, and Matthew here, and we're in Austin, Texas. We're at the AC Hotel. What a beautiful day. Obviously, Ann, you look tremendous.
Thank you.
For all of our listeners out there, you really need to get the visual component. Ann is wearing some awesome shoes. We'll tell a little story about how I know about this outfit. Believe it or not, I do know about outfits. And more importantly, we're going to be talking about.
Yeah,
We're going to be
I
talking
like
about.
I like that you call it an outfit.
It is an outfit.
Yeah.
Right?
Yeah.
She's like a superhero. So we're going to be talking about something that I'm actually an expert on, and you guys are experts on. So it's going to be sleep, which you guys are experts on, and then divorce, which I'm an expert on. So this episode is called Sleep Divorce. And this, Ann, I'll be honest with you, this idea came, you do these amazing, I don't even know what to call it. I don't want to call it a post because they're more than that. But on Ann's social media, Damn Good Sleep, that's DAMM, Damn Good Sleep, man, you always have these awesome messages during the week. And this one spoke to me. Not only do you come out and you say like what the topic is but just like little nuggets of information. I thought, we really need to do a podcast about that. All jokes aside, yes, I've been divorced twice, but sleep divorce is serious, right? And although I'm goofy and I'll probably say some goofy things this episode, I really kind of wanted to dive into it because in that short little clip there that was probably a minute long was so much information that I think we can really unravel it and make it an hour episode. So for our listeners out there, make sure
you really want to pull it out.
I do. I really want to. And I'm not the only one, right, Dan?
You wanna
So for our listeners out there, please like and subscribe on any of the platforms we're on. And again, you definitely need to check out Ann's outfit. And Brandon and I are matching today, so please catch us on YouTube. So jumping in, I forgot, Brandon, you're also an expert in divorce. You didn't think I was going to start that way, did you?
No, yeah.
He's an expert in marriage now.
I was going to say, right
not
now
divorce.
I'm an expert in marriage.
Exactly.
Well, I'm just,
exactly.
I didn't
Very
want to.
happy
I didn't want to
marriage.
leave you out of the.
No,
thanks. That's right. You're a sleep expert.
But I'm a
divorced.
sleep expert.
You are.
Well, no, I don't know if I'm an expert, but I do sleep.
You're pretty good.
I'm good at sleep.
So, Ann, I want to say it was either this last week, a Wednesday or Thursday, you posted it, and it really touched me. We've talked a lot about sleep divorce before, and we normally just think it's the typical what? Your husband's snoring, he goes in the other room, and then we stay apart, and then through the years they do that. It's so much more.
Oh, 100%.
Please share.
100%.
Please share.
So, I mean, I think when we're talking about sleep divorces, it's interesting to think about that. There sometimes are positive and negatives of sleep divorces. Sometimes we're doing sleep divorces as temporary measures because of the fact that maybe we're on different work schedules and you going to bed at a certain time is going to disrupt my ability to stay asleep. And so we do that as a temporary measure. I know that when I was a resident, it wasn't termed a sleep divorce. Like my husband, my then fiance, we weren't like, oh, we're having a sleep divorce because you have a crazy work schedule. But that's what it was ultimately. He slept separately from me because of the fact that we were on just two different schedules. The reality is that the negative of it comes when there is a bed partner who is having significant disruption in her sleep. Most frequently, we're referencing it based on snoring or features of obstructive sleep apnea, but there's other reasons for it.
Sure.
There's REM behavior disorder, there's restless leg syndrome. There can be also circadian rhythm disorders where it's a more permanent, we're on different schedules that are creating sleep divorces. And it's important to recognize this because this is the nidus for further demise that has demise, not just because, oh, we're sleeping in separate beds, but because generally we're looking at the tip of the iceberg. We're looking at the fact that we now have a sleep disorder at the center of it. That sleep disorder has its own consequences, whether that is I have different behaviors, I have different mood, I have different tolerability of you. But then also, what is the consequence of the other person's sleep? Many times, the person who is the non-snorer, for instance, their sleep is so negative that now they're just like ready to pounce at any minute. So it's the source of fights.
Well, and we know that there's the emotional, psychological component of not getting enough sleep. And so if you're the person with the sleep disorder, we already know the statistics show you're 5 more times more likely to suffer from depression. You're 6 times more likely to have anxiety, mood disorders. We talk about that kind of stuff. So you're already in that realm, which makes it easier to kind of have the fights and stuff like that.
Yes.
But then if you're the one, the non-snore or the affected partner, that your sleep is getting disruptive, and we go back to like having a baby, and like we see like that's tough on partners because nobody's getting sleep.
Yes.
And when nobody's getting sleep, everybody's on edge.
You're right.
And when everybody's on edge, fights happen.
Yeah. And in addition to those mood disturbances, you now are also compromising your impulsivity, your judgment. So things where you have, even if you had a partner who maybe has depressed symptoms or is more anxious or maybe more reactive, that you would just let roll off your back, you now are equally as reactive. And so unfortunately, it doesn't even stop there. And I think some of the things you were referencing, Matthew, is the fact that when we look at the consequence of, let's talk about snoring or sleep apnea, many times as a medical field, we're talking about the blood supply to the heart and the health of the heart. But the reality is those same blood vessels that are feeding the heart, and we're worried about atherosclerosis or the clogging of those blood vessels that are going to compromise the function. Those are the same blood vessels that are feeding down here. And so therefore, things like decreased libido, erectile dysfunction, and even female sexual abilities start to become compromised. And so when you're talking about a sleep divorce, you are talking about an overarching reason for lack of intimacy, lack of affection, and lack of really a healthy relationship.
Yeah, one of my friends who for years I knew he had like sleep issues and begged him to get on a CPAP and begged him. And he would say like he'd have these short-term memory things. So for example, he was going to buy something, like would forget stuff. And then his wife at the time was so upset that she took it like, you know, I'm not valued. You're not listening to me. And he was just short-term stuff. So, you know, I get both sides, but more importantly, I think about just the partnership. Take it out of OSA, take it out of snoring. We keep saying snoring.
Yeah.
Someone who's wearing a CPAP mask.
Yeah.
Right. And my bed partner for years, she had a CPAP.
Sure.
And it would fall off. It would blow on me. It was noisy. This is early on in the stages of 99 through 2002. You know, CPAPs weren't exactly what they were now with the mask fit and everything. And so that was to a point where I would find myself going to the couch.
Yep.
Find myself. Now, that is not the reason I went through a divorce, but I can feel it because I'm like, okay, it's just any kind of disturbance. You said children. 100%.
Yeah.
You know, when Mia was born, my daughter, my wife wasn't able to breastfeed. So it actually kind of helped me to do part of those feedings with formula, but I'd have to get up in the morning or get up in the middle of the night and do those. And so I've been there where I've been sleep deprived and not necessarily conscious, frustrated that this is keeping me up and I have to get up, I have to go to work, I have to travel, but I could see where then it would become that. And I couldn't imagine your husband going to you going, we're having a sleep divorce. Like no one's going to use those words, right?
No, but I guess the question is a sleep divorce okay if it doesn't cause? So you mentioned like having different schedules.
Well, I was thinking of offshore workers or people who work night shifts at the refineries in Louisiana.
Totally.
They sleep with two
different schedules.
Yeah.
And it's interesting to see now. And I think snoring is the main one. Obviously, that's where I see patient after patient after patient that's what's bringing them in. It's the sleep divorce. And I've seen how that impacts relationships for those people.
Right.
But I guess, you know, we're seeing some interesting things. Like there was a report that came out with, it was a custom home builders report. Something like 65% of custom built homes nowadays are being built with a separate bedroom for like 2 master suites, like not intentionally people going into this and being like, we just sleep in different rooms. We just sleep in different. And so I guess the question is, do we think that sleep divorce is okay if it causes those issues? Or does sleep divorce ultimately lead to loss of connection, cause I'm a cuddler. and I do not
too.
sleep well. I do not like
I'm the total opposite.
I
Believe it or not,
do-
you would think with my personality and his
Yeah.
personality,
No.
Yeah.
we're
Yeah.
not.
So you guys don't like to cuddle?
Not I don't. He wants to every
I'm
night.
on his back.
Yeah, and
all
I'm
the
like,
time.
get
Like,
off.
You know, and he's like just
Oh, I'm
pushing me.
sweating.
Got it.
But like I'm like, you know, that for me that's like a connection.
Yeah.
It's
Sure.
feeling
Touch. It's one of the love
touch.
languages,
Yeah,
yeah.
exactly. And so there's the touch, the connection. So if I lose that for too long, I start to feel disconnected.
Yeah.
Wow.
And so I just wonder, like, does sleep divorce lead to disconnection and divorce? Or I mean, what do you think?
My great aunt and uncle, when I was growing up, so my great uncle raised my father after the age of 11, and my dad's dad died at a very young age, and so he moved in with them, and they were very wealthy, all the way to the end. And Holland and B, I used to love to go visit their house in Garland. It was huge, had these wings and all that, and I used to go in their bedroom, and it would freak me out because they had two twins, beautiful ornate headboards,
Sure.
but two twin mattresses.
Yeah.
And I remember as a small kid, you know, driving back to Houston going, Mom, Dad, where do they sleep? They go, well, that's their bedroom.
Yeah.
You know,
Yeah.
be careful in their bedroom. I'm like, that doesn't make sense because
Yeah.
my mom and dad have one bed.
One bed.
Yeah.
So, and then you look back at like the honeymooners.
I
or
was going to
these
say,
other
I
sh-
Love Lucy.
I
and
Love
all
Lucy,
those.
yeah.
Yeah,
Lucy,
they
Lucy,
all
yeah.
were separate beds. That was like, yeah.
separate beds.
Yeah.
So you talk and you bring this statistic up many times. Back then in the 60s and 70s, people were getting 8 hours to 9 hours of sleep.
Yeah.
Could that play? I mean, I'm curious.
Yeah. I mean, it's a possibility. I would say that most of the time when we look at the different duration in sleep and how that it's evolved over time, it really seems like it's more reflective of societal's prioritization of get more done, right?
Oh, wow.
And so it's that get her done mentality.
Shit, I read a book that changed me. Get
Yeah.
things done, GTD, and that's hilarious.
And so the reality is that I would say the bigger driver probably is that we think we can expend our sleep in sake of being able to get a lot more accomplished. But the reality is that I think we're biased in knowing that when you do that, you actually become less productive. Now, in regards to the dynamic you even described, the question would be, does that even represent a sleep divorce? Because many times sleep divorces is not even that you're in separate beds, but you truly are in separate rooms. Like your
Right.
schedule is different,
Right.
your bedtime routine is different, where you're sleeping is different, the whole 9 yards. It is a true like separation of church and state. Now, the reality is that when I look at the features of sleep divorce in most scenarios, and again, this is not a one size fits all, so I don't
Okay.
want people listening to this to say that this is always applicable, but I would
Right.
say more times than not, sleep divorces for me are a symptom of a bigger problem, right?
Wow.
And so when you're talking about this symptom, we're talking about there is something at the root of this that may be medically based that needs attention, right? So I would give an analogy of that. If you are a parent and your child is 2, 3, 4 years old, and it is not yet speaking, it's not yet using words, and you do courses like, I'm going to teach you sign language, but you don't bring that to medical attention because you're able to figure out what they need,
Right,
right? You're able to figure out what they need, and it doesn't interfere my day, and it doesn't seem to interfere with their day. Is that the right medical course? No, the right medical course is to make sure that their hearing is okay. Make sure that there's not something else that is compromising their ability to speak. You would get physical therapy, occupational speech therapy, whatever it is that is necessary to help in facilitating a solution for the problem. When we see sleep divorces, this is not facilitating a solution for the problem. It's a Band-Aid to be able to ignore it and continue to go on with our lives without actually identifying what is the cause of it.
So one of the, they did like this focus group, and one of the guys shared that he had some symptoms of not sleeping well, and it affected his partner. He used two examples. He flies a lot, and he was flying up to Pittsburgh. And so he went and he had to change his flight, and the lady behind the counter was very large chested. And so just consciously he said, I need 2 tickets to Pittsburgh. And the lady goes, excuse me? He goes, no, I'm sorry. I need 2 tickets to Pittsburgh. You know, messed up. And I said, is that a joke? He goes, no, the same thing happened this morning when I was with my wife. I asked her, in my mind, I was asking her to pass the syrup. I said, well, what did you say? He goes, you ruined my life. I'm leaving. Okay, that's just a joke. The reason I say that is that the communication,
Yeah.
we need to talk about the communication piece. your husband went to you during your residency and y'all had some kind of agreement saying you go to your wife and say, I need snuggling, right? Where does communication fall in this? Because I agree with you. Everything's medical, and not everything. If we're not doing that, but I'm talking about the sleep divorce, right?
Yeah.
So how does one who's listening to this or watching, how do you communicate if her husband's been in the other room for 3 years now on a CPAP or just snoring or whatever? Is there any advice? You guys see this all the time. How do you start that conversation?
Yeah. So going back to what Ann was talking about, like the separate room situation ends up being the Band-Aid approach. So you have someone who has a sleep disorder. You have someone who
has been diagnosed with the sleep disorder.
Well, maybe
And
they
maybe
haven't.
not.
Maybe
Sometimes
they
they're
haven't.
not.
Yes.
Yeah.
And I would say a lot of times
I was
they're
going to say
not.
that's the bigger
A
call
lot
to
of
action.
times
Yeah.
it's like they just know that their sleep is disrupted. It screws up their sleep. And so there's tension. And it's like, okay, either a demand that you go to the couch or you go to the other room, or you take it upon yourself if you're the one that feels like you're disrupting your partner's sleep because you love your partner and don't want to impact them. I have a great story about this because this is really what got me into this field. When I started treating sleep apnea, and for me that's our stick. It's OSA, sleep apnea, oral devices,
obstructive sleep apnea,
obstructive sleep apnea, snoring, and Dr. Kathy Wilson, hi Kathy,
love you,
Mama Bear. She sent me one of the first patients that she referred to me when I started. This was like my second patient to treat for sleep apnea. She had been diagnosed already, but it had been years before she got tested. And so she tells me, like, one of her driving factors when she comes into the practice is my husband and I are getting ready to celebrate our 25th wedding anniversary. I said, that's awesome. Congratulations. And she literally like breaks down and she starts crying. And she says, we're going on a cruise for our 25th wedding anniversary. And we're like, and she's feeling not excitement. She's feeling stress and worry because then comes out, I've been sleeping in a different bedroom for the last 7 years.
Oh, wow.
And so I'm worried, my husband, his sleep is important. He still works. And if I disrupt his sleep, it affects his ability to work and And then, so I've been sleeping but we're going on this cruise. And if we've been on a cruise, you know how small the rooms are. Yeah. Very confined space. And she literally, her words were, I'm so scared that I'm going to ruin our anniversary.
Wow.
And so when of course, young
You're like, I'm going
to help you.
Exactly.
So I'm like,
you're like ripped open the S on your chest.
Yep. So I'm like, okay, no problem. We got to do this. We got to go. So here's what we're going to do. We're going to rush your device. The only device I knew how to make at the time was this big bulky pink thing from Somnomed. and I got her a Somnomed
classic
Somnodent Flex is what I got her.
Okay, Flex were good.
And so we got this device, and
she's like, "I'm so sexy now."
Yeah, and I deliver it to her, like literally, like the week before she goes on her cruise. And so I'm just like, "Okay, here's how you change
delivered
it.
in time.
Here's how you advance it, and just move it, and and everything, and we'll see what happens." So she takes it. She goes on her cruise. She comes back about a month later for her follow-up visit, and I'm talking the light in this woman's eyes.
Love it.
As she hugs me and she says, this thing has changed my life. She says, first of all, within 3 days, I got the snoring to stop.
Great.
Okay. Now, the cruise was awesome. The cruise was awesome. We had an amazing anniversary trip.
Awesome.
And that combined with the fact that now back at home, I'm back in bed.
Wow.
This has rekindled my marriage. I feel so alive in my marriage again. Like this was a huge emotional and psychological thing for her to feel alive and wanted and with her husband.
Yeah.
And it made the biggest impact. And when this happened and she's telling me this and she's so excited and she's like, and I'm back at the gym. I've already lost 10 pounds. I'm like,
love it.
And so, that was really for me, and I'm lucky that was my patient, because I didn't have the patient who had the jaw pain and it didn't work for, because I was like, holy shit, we have to do more of this.
I love it.
Like if this is the impact that it can have on someone's life, we have to have it. So obviously for her, like that meant a lot to her to be with her husband and to share a bed with her.
Well, and
husband.
if she, no jokes, like, so that's skin on skin. Like cuddle. I mean, that's what I'm saying. Like, how do we approach these conversations? And maybe this podcast is meant for someone who's listening to just have that conversation with your spouse, with your significant other, to say, I want to get back in bed with you and sleep with you. Yeah. And this is what I think, or go see a I mean, that's why you guys are awesome. Thank you. That's a great story.
Yeah. No, it was, and it really was what spurred me. I had another call just recently. This is a different story. My divorce attorney calls me.
Well, we are talking about sleep divorce.
And he's like, yeah, sleep divorce.
Yep.
So my divorce attorney calls me. He's like, hey man, I really need your help. And I'm like, what do you mean you need my help? I was like, I'm not on the clock, am I?
Yeah.
He's like,
is this costing me $150 to talk to?
He's like, dude, my wife is snoring something awful, and I just don't know how to
see
again.
The conversation.
He's like, I need to have this conversation, but I don't know how to have this conversation.
Sure.
And can you help? And so, I was like, yeah. And so she ended up coming in. We treated her. He calls me back and he's like, man, this is awesome. Thank you guys so much.
Yeah.
Like, 'cause he's feeling better, and so there's like this tension and this stress and this everything builds up when you're not communicating these things.
And so again, I cannot stress this enough for people who are watching. I mean, Brandon just gave two great examples of reconnecting, right? And having that initial, I call it a critical conversation. Mm-hmm. And we have those throughout the day, whether most of us think of critical conversations that have to do with life or death or business.
Well, this is life or death. This is life or death, right? I mean, the reality is that we're not talking about a nicety of just getting people back in bed together. We are talking about something that is life-changing.
Yes.
And it's life-changing not only for the person who's experiencing the sleep disorder, but for their partner and many times their family and their work colleagues and their friends. Like the trickle effect is
Think
huge.
about what they are the parents are the role models
some
for
people
children.
even call that the butterfly effect.
Oh, look at those shoes.
That would be very appropriate to term it that.
Yeah.
And if it's not called that, we're going to call it that.
I think that's what I've heard of that. Have you not heard of that? The butterfly effect? Like it's like the
Wasn't it a
ripples?
movie with Ashton Kutcher?
Yeah.
Maybe.
Look at Danny's like, it was No, you're making a great point.
Yeah. And so with these critical conversations, I think it is really important that being able to know you're framing it from a place of love, and not a place of scrutiny or embarrassment or some form of negativity. And so I think that it really comes down to just basic principles of any relationship. And so very frequently I always tell people, like, it doesn't matter what relationship. My dad, since I was a little kid, would always be like, he's old school Italian from New York, right? So he's like, trust, respect, communication. You don't have those things, you don't have any relationship. And so I use that every day for a variety of different situations where I'm having a relationship, whether it's a business relationship, a friendship, a romantic relationship, etc. And so if you have trust and respect, being able to have open communication should come part and parcel with that. And really being able to frame it in that it's not, I don't want to talk to you about this just because it's bothersome to me, that it's an inconvenience,
There you go.
or that it hurts me. I have true concerns of what it may be doing for you and also what it's doing for our relationship.
Us. Yeah.
Right?
Yeah.
And so I think when you can frame that conversation in one that is vulnerable, right? Because it's uncomfortable to be vulnerable, and it's uncomfortable to provide feedback to a loved one where you're afraid that the words you're going to say may be hurtful. Being able to choose those words and ones that are coming from a place of true caring and concern, I think does transform it to being more likely to result in positive action that will get you back to the point of what Brandon has described of getting you guys back into bed together. But the reality is that what he's described in that first scenario is not just the only one.
Right.
The fact that it was life-changing for her, that glow was probably there because her biology was actually
100%.
doing what it should, right?
Yep. So, because now we're not talking about, I'm just back in bed.
Right.
We're talking about, I'm just back in bed, but I also
I'm
have
breathing.
a longer fuse.
Yes.
Exactly.
And
My
I'm
temper's
Exactly.
not so short.
Right.
Exactly.
We're also talking about, I'm not as anxious
Right.
because I'm sleeping better. Okay.
Yep.
So because my sleep is treated, I'm not as anxious. We're talking about the cognitive things that you mentioned. Like when all of those things improve because you improve your sleep, everything, that ripple effect, going back to what you said, is okay.
Butterfly
Well, maybe I'm a
effect.
better wife. Maybe I'm a better mother. Maybe I'm a better daughter.
Right.
I'm
And I
using
just
women,
feel
but it could
better
be
for
son.
myself.
Maybe I feel better for myself.
Yeah.
Maybe I'm a better me.
Yeah.
Maybe I'm a better coworker, a better boss, a better leader.
Yeah.
I mean, so all of these come into play. And,
Yeah.
and
Something that you mentioned earlier, Brandon, that kind of ties back into this, and it's something that I'm actually going through right now. I think,
erectile dysfunction.
well, we'll talk about that later. But on a serious note, I had bed partners, right? I was married, my first marriage, I was married for a long time. I was 14 years, went through a divorce, and then I got right back into a relationship with that person and married for 9 years. And then I got divorced, and then I was single.
Yeah.
And so I started sleeping by myself. Now, traveling, as we've always talked about in each podcast, we all travel.
So do you not call them a bed partner if they don't wake up with you the next day?
I'm talking about a bed partner. That's a good one.
I'm just wondering.
Look at my face. If you're watching this, I'm a little embarrassed. No, a bed partner, period.
Okay.
You're right. They could be a one-night stand. Not that I've ever had any.
Yeah. I don't even.
But if I did, or if I was dating somebody, let's say I spent the night with them, I'm seriously, there was such a change because I was always used to somebody being there.
Sure.
Always, and you had said something even before we shot the podcast, full disclosure, we actually talked before we video, but you did say something. There's actually studies out there. Like I know friends of mine that love to travel because that's when they get their most optimal sleep.
Yes.
And sleeping by themselves without a cuddler, without foot touching, without
Yeah.
the sheets being pulled on and off, without one being hot, one being cold.
Getting up to go to the bathroom. that
Bathroom,
kind of stuff.
they sleep great. So for me, just personal experience, and I'll ask the question, it was such a transition. And to this day, when I stay in hotels and all that, I stay, and Dana stayed in a room with me. I sleep on one side of a king size bed.
Yeah.
At my house,
Yeah.
I stay on one side of a king size bed. And so I just started asking random people who I know that are single.
Yeah.
I'm like, where do you sleep in the bed? They're like, what are you talking about? Where do you sleep? And all of them are like, the middle.
Yeah.
I sleep in the middle.
Oh, that's so funny.
So I'm
Funny.
curious. I don't know.
I sleep on one side.
I
sleep
always
on one side
I
too.
sleep
Do
on
you?
one side.
The
Like,
bed looks
yeah.
like it's been
Yeah.
like made
The other side
perfectly.
is
Yes.
not touched at
Yes.
all.
Exactly.
Yeah.
So-
and even when I travel with my husband, we have to assume the same sides
Yeah.
that we normally would
Yeah.
when we're at home.
Yeah,
like I
so,
can't
yeah.
flip on the other. Like I'm like
So-
no.
So y'all are helping me here. So
Now it's interesting. That's
Yeah.
funny because normally we're like that too. But Jenny and I have two houses, one in Canada, one
Yep.
here.
Yep.
And we sleep in the different houses. We have opposite sides of the bed that we sleep on.
That's 'cause you're
Really?
in different countries.
Yeah,
It's so
Canada
weird.
doesn't
They
count.
it's
do all
kinda
weird
like,
stuff
It's kind of
in
like when you
Canada.
flush the toilet in the different hemisphere, it goes the opposite way. Yeah. So
Maybe
So
that's
my
what's happening.
Yeah.
so
You're
my
entering a
point,
vortex.
my point being, there was a transition there,
Yeah.
right? And there was a couple years there where I was truly single. All jokes aside, truly single, slept by myself, and then I got into a relationship. And the sex and all that, well, we could joke, but I'm talking about actual sleeping together was
Sure.
miserable.
yeah.
It was so odd and
Because
weird.
you got so used to sleeping by
Yes.
yourself, and you're one of those people that
Yes.
would prefer that. And so I think that's the interesting thing.
So
And that's
I-
kind of my question.
Yeah.
Is like, okay, so some
Does
people,
that make sense? Before okay,
Mm-hmm. Yeah, yeah.
I want to make sure they understood what I was saying.
Some
Yeah.
people sleep
Okay.
better when they're by themselves
Yeah.
because their quality of sleep is
Dude.
not interrupted or
It's-
not whatever. So we say, okay, well, maybe you get better sleep if you sleep by yourself. But then you have all these other studies that say, typically speaking, that people who sleep with a bed partner have longer, healthier, happier lives and things like that.
So I am literally going through that. When you said that earlier, I went, oh, I can't wait to bring this up because I'm in a relationship now and a healthy relationship. And it's just really hard for me because I've talked about this on prior podcasts, even showed my whoopee. I sleep on top of covers. I never sleep under covers at hotels. I just have a routine. We talked about my sleep hygiene. I have to do this certain thing. Well, when you're trying to be sexy and cool and in a new environment, and you're trying, it's hard for me to sleep and I hear everything. So like I'm a light sleeper. I didn't know I was a light sleeper, but now I notice like when someone moves, when someone's going on. So I'm sure there's listeners out there that understand what I'm talking about. I'm in a new relationship, so I want to make it work. So it's just been a transition.
Yeah.
But when I go right back on the road, I'm on that one side of the bed with the whoop gone, sleep
Yeah.
like a baby.
Yeah.
So
there's
a
got to
cou-
be people.
there's a couple of things to unpack there. So first, what Brandon brings up in regards to is it better to sleep alone or sleep with someone else? This is long standing. Like we have been trying to prove this time and time again and proving it across the developmental lifespan, right?
Right.
And so when you look at the American Academy of Pediatric recommendations is to put a baby on their back in their own crib or bassinet, not with anyone else, because of the concerns of SIDS, sudden infant death syndrome, right? And so therefore we're saying, okay, that's the best way. Internationally, we don't necessarily see that, correct? We see that there are families who do co-sleeping. And this is not my positive endorsement of going against the American Academy of Pediatrics. It is really saying, let's observe and unpack exactly what the question is which is better? And so I think there are so many factors that go into what we see. One, there's cultural factors, right? Where it's not only mom and dad, it's the whole family. I can tell you, growing up in my household, I was in my parents' bed. My brother was like on the floor on a mattress holding my dad's hand. Like there was a ton of people who would sleep together. And so there are some of those factors where this is where you feel your protection, your comfort, etc. I think that the most important component, and I don't know that any research has really dug into this particular piece when studying this, is understanding the person's perspective before analyzing the quality of the sleep, right? Because if I put you and you in a study together, and I say sleep alone and then sleep with someone else,
I've already got a bias.
You both have bias.
We both have bias.
You both already have bias.
Right.
I'm going to see that your quality of sleep is so much better when you have something else. And I'm going to see that your quality of sleep is so much better when you're independent. And so probably the bigger driver is not necessarily the presence of the bed partner. It's what your preconceived notions are or what your areas of comfort are. Now, what's interesting though is that even when we look at co-sleeping for like your older kiddo, where maybe we're past that stage of SIDS, but you're now maybe 2-3 years old. What is interesting is that studies do demonstrate that when you take the toddler and you put them in the bed, no one sleeps well. The child is like a starfish, and you take them out of that bed, parents sleep better, and the child sleeps better when they're independent. That makes me think that there probably are developmental milestones that reinforce these different independence, codependence type of pieces. Humans by nature are pack animals, right? We are not built to live in isolation. We are built to really be affectionate and with one another. And so there are probably factors that we experience in life that are going to push us into these kind of buckets of, are we more likely to want to be co-sleeping versus independent sleepers? And so I think wherever you are right now in your journey in life is really just doing that own introspection of like, how do I sleep best? And then if you find that you're a Brandon or a Matthew, then trying to adopt a situation that would fit that. Now, if you're a Matthew and you're like, I really prefer to sleep independently, but I have someone who I love or they love me and we want to,
Brandon.
then we need to, then we need to figure out what are acceptable in-betweens, right? And so acceptable in-betweens may be figuring out, are there cuddle time and then separation? That's actually where I live. I'm a person who, I like the cuddling, but when it comes to the actual sleep part, I like to cuddle a pillow. Like not necessarily my husband. And my husband, like he always criticizes. He's like, how was your sleep in your fortress of pillows? Because it's like I just have pillows surrounding me. Right?
I am the same. That's hilarious.
And so it's not that I don't want to be affectionate. So in the middle of the night, there'll be times where like I'll put my hand over on him.
Right. I'll put a foot out.
Exactly.
Yeah.
But for me to get my best sleep, it actually is like caressing with a pillow and like in this particular position. But I also am the biggest cuddler with him when I'm more awake and like falling asleep. But when it's the actual sleep, I'm like, okay, I turn this way, you turn that way.
Yeah. So if you were talking about cuddle meaning sex, I'm the same way. I like to cuddle a little bit, then I like to sleep. But I'm with you. That's funny you said that because the toe or like the reach out, that's good for me.
Yeah.
Yep.
That's good for me. So I'm going to put you on the spot. You could sleep cuddling the whole
I can sleep cuddling all night long.
Yeah.
Gosh,
Yeah. That would be like too hot.
I can. But I get hot. I do get hot.
That's what
it's
I
too
thought.
hot. That's the problem.
What typically happens is I cuddle until I get too hot, and then I separate.
Okay.
And then I get cold.
And then you
I cuddle again, and then I separate. So like all night long.
Dan shaking his head.
Yeah.
For audience,
so
Dan
wife's like is totally messed up.
ruined.
She's like,
And she's a little bitty thing. Oh my God. You imagine this hairy thing.
And poor Jenny, she gets like if she's not cuddling, she does it like sometimes, and in my sleep I don't know what I'm doing all the time. So sometimes she just,
which is another reason for sleep divorce sometimes.
Yeah. She just gets, I don't cuddle, I don't go to her, I pull her to me sometimes.
Oh,
So
that's
it's like-
helpful.
yeah, so it's like, come here.
She's a little bitty thing, I'll tell you.
So, but you brought up something, and we can get back to sex now, because sex is obviously, when we talk about divorce,
Yes.
and there's
Those great statistics.
not
you
enough,
shared.
I need it, I want it.
Right.
We know, going back to sleep apnea in specific, which is what I know, but sleep disorders in general, and the impact on libido, sexual drive, sexual function, sexual dysfunction, erectile dysfunction, male or female, not erectile dysfunction for male, but sexual dysfunction.
Well, nowadays you can't really.
But
label.
also another important component, which I've been doing a lot of, we see a lot with one of the urology practices that we work with, which is the testosterone factor.
Yep.
And the fact that testosterone is made while we're sleeping, the hormone regulation that happens while we're sleeping is where the testosterone production happens, if I remember correctly. And that has an impact on erectile dysfunction, strength of erection, you know, all the things that are sexual dysfunction related as well.
Yeah. I mean, I think, and Brandon knows this, so I work closely with low T centers. I'll give them a shout out and work in conjunction with them. I started that when I was with Philips. And so there was a very much a connection, right, with all these low T centers and putting them on an HST, home sleep testing device. We had launched what we call the Night One back at Philips, and they were putting them on and then putting them on a CPAP. Right. And so I was like, oh my gosh, this is all kind of connected. So although the stereotypical thought is that you go to low T centers, you get shots of testosterone, but most low T centers, they all will prescribe. There's always a sleep component. Yeah, that's what I'm saying.
Yeah.
And so it's interesting that you say that. So it's almost like taking a shower without soap. And that's one of the doctors had told me that they go, we use both. So they need to be on, men need to be on testosterone, but they also need to be given optimal sleep.
Well, it's awesome to see that some providers are going this direction now, because I think what we saw for a long time was, especially with these testosterone centers that are popping up everywhere.
Right.
And men's health is a field like where men want to be healthy. They want energy. They want their drive. They want to perform in bed, in the gym, whatever it is. Right. And so a lot of, I think, men were going in and they had low T. And so they would get the injections, they would get the testosterone therapy, but then their T levels would go up. But they maybe they were lacking some of the energy. They were lacking some of the symptoms. And so some of the symptoms of having low T, lack of energy, that kind of stuff, it was really symptoms of poor sleep or sleep apnea, but because that wasn't being looked at. So now it's really cool to see that there are places that are, and that's the urology practice we work for. If you go in with low T as a complaint, you get a blood test and you get a sleep test. Like right off the bat.
I think one of the things that's so fascinating is that the description of kind of like the win that you're describing right now, where sleep is being considered as a part of the care pathway, is really a direction we need to go in so many different areas. So my area of expertise is in central disorders of hypersomnolence. The typical journey for a person who has central disorder of hypersomnolence, so things like narcolepsy, idiopathic hypersomnia, they say 3 to 5 providers before finally being diagnosed. And that generally is a journey of 8 to 10 years. During that journey, they usually are being misdiagnosed also with 3 to 5 other diagnoses. Things they get diagnosed with are things like, you have low thyroid. They really didn't have low thyroid, but that's something that they're thinking, oh, your TSH is maybe a little bit off. Maybe this might help here. This may help. They get diagnosed with things like Lyme disease or chronic Lyme, which is not an actual diagnosis. Lyme disease is chronic Lyme. You can get treated from, but you may have persistent sleepiness or symptoms that are related to something else. And then you get diagnosed with things like depression.
I was going to say.
Like, so there's all
Anxiety,
these other things
depression.
that do have features of sleepiness or fatigue. And if you're treating them and you're not getting better, the call to action is coming back to that. But also the call to action is understanding what is the probability of a person who's presenting with this problem also having another condition. And so when you're talking about someone who's coming in and you're going, Mr. Johnson really isn't working the way that I would like him to work anymore.
I hate that you call your husband's penis that. That's the second episode.
But the reality is that when you look at studies that evaluate just for sleep disorder breathing alone, you can look at it bidirectionally. Are you a man who has obstructive sleep apnea? The studies, depending on which study you look at, it's anywhere from 40 to 80% have erectile dysfunction.
That's crazy.
When you go the flip side and you look at studies of individuals, men who have erectile dysfunction, there are studies that demonstrate up to 92% have obstructive sleep apnea.
Yeah.
And so again, when you're thinking about this problem, it's important to think about it in regards to, are we getting at the core or are we just treating symptoms around it?
Well, and I think that's the maybe the improvement that our healthcare system needs. Like the fault of our healthcare system.
Oh, here we go.
In many cases, I'm sorry to get into this.
Oh no, watch in.
But we've stopped looking at the entire human body, and we've specialized in you take care of this and I take care of this and you take care of this.
Separated
and so everybody's
siloed.
Everybody's siloed and nobody's looking at that. And I don't know why sleep testing isn't more prevalent. Sleep apnea is more prevalent than asthma or diabetes.
100%.
Everybody gets their A1C checked and their glucose checked when they like their annual physical, and nobody gets sleep tested.
That's right.
But we go back to what happens in that system is that we end up treating symptoms, not causes.
Yeah.
And so there was an interesting study. You mentioned the study about erectile dysfunction and percentage of people that have sleep apnea. There was a follow-up study on the treatment of these patients, and they took a group and they said, okay, all these people have erectile dysfunction and sleep apnea, and this group gets Viagra Cialis, and this group gets a CPAP machine, and they use it. Okay. And then they look at the results in terms of, and I always wonder how they measure the improvement in erectile. Like, is it just a survey? Do they actually?
It's probably patient-reported outcomes. I don't. Yeah. Yeah. I think it's patient-reported outcomes.
I
use a blood pressure cuff.
I was going to say, I think they should go deeper there.
That's what she said.
You? but they look, and guess what? The CPAP group did way better than the Viagra group.
Yeah. Not only in terms of the erectile dysfunction, in terms of the actual performance, but also sexual drive. Yeah. So there was a recovery of not only the function, but also the function.
But how many people that see a doctor for erectile dysfunction never, ever, 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 ever get a sleep test? They just get given the pill.
A bunch. They get the blue pill. And guys, nowadays 100%. You can literally... I mean, we all hear the commercials. You could literally, Dan does this all the time.
Yeah.
You
can just go on the internet. You don't even need a doctor. You just go on the internet.
And the problem is, and Ann's going to talk about the I'm going to say this wrong, but you were speaking to it. Yes, those two drugs will get you hard. I'm going to use some language here. Sure. But that still doesn't help with drive, libido. What the CPAP was helping in that study was actual want and desire and wanting. You could walk around all day with a heart on. Right. And not feel and not want and not have a desire.
Been longer than 4 hours.
Yeah. And not have a desire. So it sounds like I'm making a joke, but it doesn't work that way.
Yeah.
I mean, you could be a sociopath, I guess, and have some issues and it works that way, but there's got to be something that drives that.
Yeah.
So you talk about putting a Band-Aid on it. But I would say, even back in the day when I was in pharmaceuticals, and those drugs launched, they were number one drugs for a reason. Yeah. Right? And they were overprescribed and I'm just telling you.
Yeah.
It was.
Well, it's fixed. I don't know that it necessarily was overprescribed, but it was really solving for a solution that men were embarrassed to discuss, right?
Listen, so I had friends in college when it got, right when I left college, they were getting this. They didn't need it. They were healthy, vibrant, 20. So yes, I will push back a little. Okay. I know you're a doctor, but I do think it was overprescribed.
Yeah.
Or black market given out. People were
it
taking it.
May have been. Yeah, it may have been more. Yeah, no. Because I just want to say that it's fair that I think that it's appropriate for it to be prescribed for people who need it.
Agreed.
Right? And so many times I hear people say, oh, this is overprescribed for ADHD. It's overprescribed for erectile dysfunction, because those are stigmatized as those are luxuries to have. And I want to just make sure that the people who are listening to this don't feel as though that it's a luxury for you to be able to have sex.
Thank you.
Sex is something that is a really important part of your life as an adult, and being able to have effective ability as well as a drive and desire, I think is really critically important. Right. I think some of the things that we're still not even scratching the surface on, though, is that when you think again about this very complex milieu of things that are contributing to your sexual performance, we look at men and we go, okay, you have low T. You may have erectile dysfunction. Some of the pieces that we're also not thinking through is the fact that, is it just low T and giving you a replacement of testosterone? Is that going to be the right solution? The reason I ask this question is, what is the typical prototype or the typical individual that we think of a man who has obstructive sleep apnea? It generally is a man who's over 50, who's overweight, generally overweight because of adipose, fat tissue. Yep. What happens when I give a man who has a ton of adipose more testosterone? That adipose actually
100%.
aromatizes your testosterone to be estrogen, right? And so we don't think through these pieces either. We don't think through the fact that we are thinking about estrogens and progesterones, and those things can actually contribute to higher likelihood of you having sleep disorder breathing, right? And so we think about, again, let's provide you the solution, because the thing I see in front of me right now is the low testosterone and erectile dysfunction. But the reality is that the solution of looking at obstructive sleep apnea, treating sleep apnea with potentially CPAP, but weight loss may actually be your winning ingredient to saying, now you don't need the testosterone supplementation. Now you don't need the Cialis or the Viagra or whatever else. And maybe you don't even need the CPAP anymore.
By losing the weight and doing
exactly.
modifications.
So really, again, taking that step back and going, what is the phenotype of the person who's in front of me and what can we do differently? One of the things I also want to get back to earlier is the fact that I loved that Brandon gave 2 examples of people who had obstructive sleep apnea who benefited from a dental device that were women. Based on all of the screening tools that are developed and that we utilize on a clinical basis every single day are based on men being the target audience and women generally being mislabeled and misdiagnosed as insomnia. They're telling you that I'm waking up frequently in the night, I'm not satisfied with my sleep, I'm not getting the right number of hours of sleep, I'm waking earlier than desired, and I can't fall back to sleep. They typically are perimenopausal, postmenopausal, and they look like me. They have a narrow face, they're not overweight, etc. I can tell you, I 100% am going to have obstructive sleep apnea when I go through menopause. I know it because my face is narrow. I have a narrow airway. I'm going to be collapsing all the time in terms of my airway. And so I love the fact that the example you gave were women, because we generally turn a blind eye and think about all the negative experiences they had in regards to I'm gaining weight, I'm less satisfied with life, etc. as well, you went through menopause and your hot flashes and you're snoring. That probably is just an inconvenience. Let me give you a sleeping pill so that you can sleep better
here's
at
a
night.
Sleeping pill. Here's some estrogen. Here's some whatever the case is.
Yes.
And you're right, because women lose muscle tone like mad during menopause.
Yes.
Like way more than men. Men don't go through.
I know.
Anyway.
They go through menopause.
So the muscle tone, when they lose that, so prior to menopause, we know there is I want to question this statistic too, because we say there's a 7-to-1 male to female ratio prior to menopause. After menopause, it's 1-to-1. Like that's how much women close that gap.
There was a statistic you gave in one of the prior podcasts, 2-to-1.
Yeah. And so, and depending on what study you read and what you look
100%.
at, but women after menopause absolutely have it. Now, what I think is very common before menopause, though, never gets diagnosed as sleep apnea, because
100%.
maybe it's not sleep apnea. Maybe it's just upper airway resistance syndrome. Maybe it's that breathing narrow. So they're not going to get a diagnosis. But these are the women that are, 40-year-old females with muscle pain, jaw pain, headaches, fatigue, and I see this time and time again. And so they if they're lucky enough, their doctor gives them a sleep test or a sleep apnea test. It almost always will come back negative for sleep apnea
because it's a home test.
Because it's a home test, even a lab test, maybe it comes back the AHI is 3.8, and they but they have all these arousals that are happening. So there is sleep arousals, there is sleep deficiencies.
Well, also just not to interrupt you, but just to interject, because it's a really very important point. When we're talking about the diagnosis of obstructive sleep apnea, when you're using a home test, you're generally using like a respiratory disturbance index. It's not a true AHI, right? Because we're not incorporating EEG, so your actual sleep states. When you're looking at even an in-lab test, we're saying an AHI, but again, we're looking at total AHI. The predisposition for women who are perimenopausal, postmenopausal, typically is that you're a REM-specific obstructive sleep apnea, and as a field, we don't do anything about that, right? So your total AHI is less than 5, but your REM AHI is 45,
20,
right?
30,
And the reality is that the story they're telling you also fits that. They're telling you that I tend to have more fragmentation in the second part of the night. I wake up earlier than desired. I can't go back to sleep. That follows your normal progression of REM. A little bit of REM in the beginning of the night gets longer. The more I spend in it, the worse that I am. And the reality is that we keep telling women and people who have the same type of pattern, you don't have obstructive sleep apnea. We tell them that you have upper airway resistance. You know what that does for you? Shoot you in the foot, because the insurances go, I don't recognize that.
Yep.
There's nothing I'm going to do.
Yep.
Breathing becomes somehow optional if I don't fulfill a specific criteria that has been predetermined based on absolutely no evidence to show that makes a difference.
Yep.
And now that you interjected, continue. I'm kidding. You may remember?
I don't even remember where I was.
I love when she does that.
No, but she's
love
100%. She's 100% right in
She's
how
the best.
and how it's
You
diagnosed,
are.
and so
And passionate.
But and then again, that goes back to, I don't want to get on the insurance driving
Please don't.
medical care soapbox.
Please don't. This
But
will be an extra long episode.
We're gonna we're gonna get along great.
Yes. Yeah.
But then you have the doctor saying, "Don't worry about it." You know, you don't have anything, even though they do.
Right.
And then you have the insurance company saying, we have a therapy that can help you. And I've seen this in patient after patient as well, but we're not covering it.
Yeah.
Right.
Okay. So then you get into, then the patient starts to question, well, if the insurance doesn't cover it, do I really need it?
Exactly.
Is it affordable? Like, we have
Exactly.
this, patients
Exactly.
unfortunately have this idea that the insurance knows exactly what they need.
Yeah.
And
So this just further highlights the stigma around sleep disorders, right? And so
100%.
the stigma in the United States is that sleep is something optional. It's a nicety. We don't necessarily need all of it. And we have not done a good job in medicine overall, no matter what field of medicine you're in, whether you're in dentistry or you're a sleep doctor or you're an ENT, of saying that, no, it's not optional. It's a completely necessary. And so we see this across all sleep disorders, of that when you put it in the hands of the insurances generally are looking at not risk mitigation, because they don't even understand the data, and we haven't done a good enough job of making sure they understand the data, because if they truly did, they would also know that primary snoring alone is associated with more advanced atherosclerosis of the carotid arteries, which then in turn means that you're higher risk for things like stroke, right? And so if they really were concerned about risk mitigation, they would be saying, hey, I want to prevent that very expensive admission. What they're concerned about is just saying, how do I keep the money in my pocket longer? And so this is a complete setup, and you talk about my social media posts, I've done posts on this, and I've done very, very specific call outs to things like CVS, Aetna, Blue Cross Blue
So
Shield.
we are going to talk about
and the reality is that those are some of the biggest offenders. And so they do things like this. They say, first of all, I don't want you to do an in-lab study, you have to do a home study, even though the person in front of you does not fit the phenotype that is going to be positive on a home study. So now I make you do that twice. The patient now is going, this must not be that important that they can wait 6 months with me doing all these home tests that it doesn't show anything. And now the patient's going, clearly there's nothing wrong with me. The
no
home test
sense of
doesn't show
urgency.
anything. Now I have to schedule you for an in-lab because these two have been inconclusive. 6 months later, now this is a year from the time that I even said that, right? I finally get you an in-lab. By this point, you have atrial fibrillation, you have diabetes, you have refractory hypertension, right? I get you in there. We then diagnose you. You now get, let's say it is a CPAP, and they go, okay, well, you have this much time to start using it every single day.
Yep.
And if you don't use it this percentage of the time,
4 hours
right,
a day, 5 days out of 7.
take it away.
we take it away. And not only do we take it away, but we don't believe anymore that you actually still have this disorder. So if you want to get it back, you have to be
gotta do another
retested,
test.
right?
Oh,
Like, and what? Like, can you imagine? Can you imagine a world where you get diagnosed with type 2 diabetes? I prescribe you metformin 200 milligrams a day, and you come back to me and you go, Doc, I've been taking it 50 milligrams every other day. And I go, that's it. I'm taking it away from you. Good luck.
Yep.
Good luck with your diabetes. When you come back in DKA, diabetic ketoacidosis, and you're in the ICU, you better bet the hell the insurance is going to slap my hand and go, Doc, what did you do?
Why
We're
didn't
taking
you
your
give them
license
metformin?
away.
Yeah.
We're taking your license away. But meanwhile, obstructive sleep apnea, which is an independent risk factor for stroke, for type 2 diabetes, for myocardial infarction, for atrial fibrillation, we now all of a sudden, that doesn't matter. It's like, you know what? Just make sure they get their asprin. Make sure they get their asprin as a stroke prevention.
81 milligrams.
So I'm glad we didn't go there. I love you, Ann. So just to kind of recap, and then I got to tell a story.
And all these insurance companies can catch me in October when I'm at your managed care conference that I was invited to speak at in Las Vegas. I'll be very happy to sign autographs.
October Vegas sounds fun. So Ann's wearing an outfit. If you're not lucky enough to watch us on YouTube, Ann is wearing an outfit. And before this podcast, she comes down, and of course, she looked gorgeous as always. And she's wearing her butterfly shoes. And she goes, "Do you recognize this? Am I saying out? Is that wrong? Don't say outfit anymore.
No, outfit is
outfit, that's
totally
right.
appropriate.
Because like you taught me how to say team, by the way.
Correct.
I always said.
Yeah.
So she comes down in this outfit and she goes, "You remember this?" And I'm like, "No." So I've told this story many times. When I met Ann, was at the sleep conference, and I heard you speak, and then saw you, and then we talked. But that night at the bar, this is what you were wearing.
It was what I was wearing.
And
I
I
just
was
come from
wearing my
doing
new
a
Braunfels
product.
hat.
Yep, I was just coming from speaking at a product theater,
Yes.
and so the whole group of us, we came out to get some food and hang out at the bar.
And not that I was at the bar. I was at the bar when they came in, and I had my new Braunfels hat on. And I go, "This matches your shit," and you put it on, and we've been fast friends ever since.
Yeah.
I definitely always like to kind of do a recap, and I'm just going to kind of pose some questions to you guys to make sure I don't miss anything. But the episode, although I got a little goofy, I love this topic, sleep divorce. And some of the things that y'all brought to the attention, not only to me, but probably to the audience, is that, you know, it's not just being in separate rooms as a sleep divorce. There could be, we might have listeners that do. Their husbands work at a refinery and they work the midnight shift and they got small children, so they could have healthiest marriage ever, right?
Yep.
So we're not saying all sleep divorces are bad and sleeping in separate rooms,
Yes.
correct?
Yeah.
Correct.
We mentioned that, you know, how we sleep. You know, Brandon is a cuddler, right? And I love how you said you could either be a Brandon or a Matthew. So we'll do Team Matthew, Team Brandon shirts.
Yeah.
But it's true, and y'all helped me.
You can get them on the website.
Yeah. and you really helped me to kind of get through I was like, man, I got so used to sleeping alone and I sleep great, you know?
Yeah.
And you gave some tremendous statistics, and so did you, Brandon, really talking about, like, you know, with men's health, we'll just speak for men real quick about erectile dysfunction and how that is directly linked to OSA. And all this stemmed from your amazing post that you put on Instagram on Damn Good Sleep. Am I forgetting anything that we want to leave our
Well,
audience
I think
with,
just
guys?
go back to that communication standpoint.
There you go.
If you're experiencing a sleep divorce, if you're experiencing a situation which is making you unhappy in your relationship with how your relationship is going, have the conversation. You know, have the conversation, bring it up, find somebody to have
Critical
the conversation
conversation.
with. Call somebody who might be able to help you. Call somebody and have that conversation to try to dig deeper and get the get to the solution of the cause, not just the band-aid of, you know, because when you just say you snore, I'm kicking you out. It's now it's a frustration thing. Now it's a you against me thing.
Right.
And now it's a I just don't want to deal with you, so I'm gonna
Sure.
like bury my head in the sand kind of a thing, as opposed to, hey, let's work together to help the situation and get to the bottom of it.
Dr. Ann?
And I think the other piece that we did not cover today, but I do think we'll probably cover in future podcasts, include we're talking about sleep divorce where people are actually, as a couple, are recognizing that there's a problem.
Oh, wow.
There are also the
Right.
people who they're avoiding
Right.
spending nights with people because of the embarrassment.
Yeah.
Whether it's
Wow.
bruxism or they do weird behavior, like quote unquote weird behavior.
Well,
I always
I
am
d-
careful to say.
Oh my
weird
gosh,
because-
that's a whole episode.
So that's what I'm saying.
Yeah.
It's not going to be covered today, but
It's a good one.
I do
a
think
great-
that it's a really important piece of that. If you're listening to this and you're going, I'm that person and I refuse to sleep with anyone because I don't want them to see X, Y, or Z.
I'm scared
Or
that they're gonna- yeah.
or the patients who I take care of who they're on an oxybate and they're like,
Mm-hmm.
I don't want to sleep with someone new and be able to take my medication. You now are making those trade-offs.
Wow.
Not only for a relationship, but sometimes of how you take care of yourself. I'm on a CPAP, but I don't want them to know I'm on a
Yep.
CPAP,
Wow.
right?
Yep.
So I think this is going to be a whole nother podcast that you guys
100%.
are going to have to tune in. Make sure that you're
Yep.
sending us your questions, your concerns, your journey, so that this way we can give you some really specific tips on how to be able to navigate
I
better.
tell you what, I love working with you guys. Audience, thank you so much for sleeping around with Dr. Ann, Dr. Brandon, and Matthew. And y'all have a blessed day.
Yep, just keeping it between sleep times.
Bam.